We're going to wait just a couple minutes because I know attendees are coming in, but wanted to welcome everyone to the TBI Topics webinar on fall prevention among older adults. So the person speaking, my name is Kelsey Kowalski. I'm the communication specialist here at Harborview Prevention and Research Center. We're partnering on this webinar series with the Washington State Department of Health. We've also been really delighted to work with the National Peer Learning Team. So definitely welcome everyone who's here with those groups. And the goal of this webinar series is to really we'd like to provide kind of a broad range of perspectives on TBI, looking at both the research and clinical care, as well as the community programs and outreach and intervention aspects of TBI. So we're really glad that we can offer kind of multiple perspectives, and we think today's webinar is really going to capture that as well. We know that our attendees are from 29 states across the country. We have a mix of physicians, nurses, EMTs, community program leaders, healthcare advocates, researchers, and public health professionals, and I'm sure lots more categories that people could fall in, so I really appreciate everyone being here today. I am very excited to introduce our two speakers. Our first speaker is Dr. Hilaire Thompson. She's the Joanne Montgomery Endowed Professor of Biobehavioral Nursing and Health Informatics in the University of Washington School of Nursing. She's an internationally recognized nurse researcher and is a core member here at HIPRC and a dynamic part of our TBI research section. Our second speaker will be Paige Denision, who's the Director of Health and Wellness Department at Sound Generations here in Seattle, and also of Project Enhance, which you'll be hearing more about later on in this webinar. She's also the chair of the Evidence-Based Leadership Council, which is a collaboration focused on growing and sustaining evidence-based self-management and health promotion programs for older Americans. So we think this is going to be a great kind of combination of perspectives. Thank you very much to our speakers for being here. We will have a Q&A session at the very end of both presentations, so please hold your questions for either speaker until the end, and hopefully we can have some good conversation. All right, well, I think that wraps up the introductions. Dr. Thompson, if you want to get started.
Thanks for that. So I'll be talking on the topic of traumatic brain injury in older adults, and then transitioning specifically to more around fall prevention, because you'll see that's the primary reason for traumatic brain injury in older adults. So despite the fact that older adults constitute only 13% of all older adults in the United States, they account for more than 25% of all traumatic brain injuries. And like all traumatic brain injuries, similarly, more than 80% of these come in and are considered mild based on classification criteria, meaning that they have a Glasgow Coma scale 13 to 15, or they have like no loss of consciousness, might be just minimal change in consciousness or some symptoms that they present after the head injury. But just because something is mild doesn't mean that it necessarily doesn't have substantive impact to the older adult. Moving forward doesn't mean that it doesn't change function. And so that's the point that why I put it in quotes as mild, because mild doesn't necessarily mean that it doesn't have something really meaningful and impactful for function and recovery. Also importantly, that when we look at this across populations, then older adults have the highest rates of death from traumatic brain injury. They have the highest rates of hospitalization, even adjusting for the numbers of older adults compared to the rest of the population. And so this is something that we're seeing more and more. It's growing numbers. And when we look across, and these are trends coming from previously from 2007, and we've gone back and looked at data before that, but the trends are continuing. Looking at data from 2006 to 2013, that the trends are consistent, that we're doing a better job in preventing TBI in younger populations. So there's been really good prevention efforts targeting, safe play, reducing inflicted head injury in children. So really good prevention focused activities in younger children, and reducing the rates of those folks coming in. But what we haven't done a good job about is, and we're seeing increasing rates, and part of this might be from increasing knowledge that older adults are a population that experience traumatic brain injury is that we're actually seeing growth of the numbers of individuals coming in with traumatic brain injury particularly in the 75 plus range. And these rates are adjusted for the population. So it's not just because there are more older adults in the United States. So this growth is pretty exponential, and you could see this, again, this trend is continuing. So while we're doing a good job with prevention and attention in younger age groups, we're really not paying I would say adequate attention to this age group, and it's certainly very costly, both from the personal perspective to the older adults, their family, but also to society. So when we look at the causes of injury and injury-related deaths in person, these are recent data from the CDC, the number one cause across both non-fatal and fatal injury is falls. And so we'll pay attention and talk about this a little bit more later on, but this is the primary reason why older adults experience a fall. And this might be mechanical fall, so they trip and fall over the sidewalk or up the stairs or something like that, or it might be something where they have actually a health-related event, like they have a syncopal event and then suffer a fall related to that. So this category of fall catches both of those. Other things that for targeting for prevention include motor vehicle crashes, where they might be either the driver or the occupant, or they could be a pedestrian as well. And certainly looking at other areas for injury prevention in this area. So when you think about risk factors for injury in older adults, they come with some unique risk factors that we need to be considering as providers, as people looking to care for them. So thinking about what conditions they have that would put them at increased risk for injury. So certainly other conditions that they have would put them at increased risk. So when we're doing our assessment and looking at injury prevention, thinking, is this someone who's a frail older adult who might have a risk for particular injury? Are there things that we can put in place around nutrition or other aspects to reduce that risk? We know that depression is associated with increased risk of various types of injury, so making sure that we're assessing for that and putting appropriate treatments. Looking at diabetes, is glucose under control, not too high, not too low. Syncope, like I mentioned, can relate to falls. Can also, we've seen a number of people coming in motor vehicle crashes related to events. So looking at those sorts of issues, cognitive impairment, vision problems, and making sure that they're attended to. Incontinence, which is an underappreciated area and attention for management because of relationship to toileting and needing and rushing to the bathroom and things like that. So appropriate referrals for those sorts of areas of management to reduce falls. Alcohol use, prior history of fall, not just because we know that that's increases the risk of subsequent fall, but also because people who have a history of fall can develop a fear of falling. And so by having this fear of falling, they've had an event, it's made them fearful that they're going to fall again. They actually stop going out, they reduce their movement, they reduce their activity, and they can actually have a loss of functional activity. And so one of the things to understand and can be assessed for is this fear of falling, and there are validated tools that are available that could be used there to assess for this fear of falling and help individuals overcome that fear of falling. It can also be appropriate in cases of people have fear of falling to refer to physical therapy to assist people if that's something that to help them understand how they could fall correctly, if that might be something that would be appropriate. Medications, looking at that med list, doing the brown bag review, looking at taking off long-acting benzodiazepines, psychotropics, anticholinergics, certainly with increasing numbers of meds that have anticholinergic activities, increasing risk of fall. We see also an increased risk mildly with patients on diuretics, usually related to urgency issues around toileting. Type 1 antiarrhythmics and digoxin has also been associated with increased risk of fall. So doing that brown bag review on the med list, seeing what meds need to be given, what meds could be taken away or reduced or changed to another category of medication appropriately. In looking at outcomes of older adults following traumatic brain injury, they're more likely to die after a brain injury that's similar to a younger adult. They have increased dependence at all injury levels. They stay with us longer when they're admitted to the hospital, and they have more likely to have neurologic decline at later time points. So they might be fine till 3 months post-injury, and then all of a sudden we see them having neurologic decline later on. And overall, their cost of care for a similar level of injury is higher than their younger counterparts. So again, increased individual, personal, and familial and societal costs. We've been interested in looking at what's the role of providers in this sort of outcome issue. And we certainly know that there are age biases in healthcare, and older adults get less aggressive treatment. They're not seen as candidates for oftentimes for health promotion programs. And so some of the things that we've looked at in our own research activities have been looking at whether or not older adults have gotten the same recommended treatment for traumatic brain injury as younger adults. And in a number of studies that we've done looking at the National Study of Cost and Outcomes of Trauma, we've shown that older adults do not receive the same recommended care that younger adults do. And there are various factors that may go into that decision making, but that could be actually some account for some of the differential outcomes that have been seen. The other piece that may play a role is under triage. And so we know that the recommendations are that adults 55 and older get triaged to level 1 trauma centers. But correct triage of older trauma patients can be difficult because there might be age-related changes that make appropriate assessment difficult. Medications can be masking some of the symptoms that you might see, other injury-related factors, and we know that under triaging to appropriate levels of care increases with age across a number of studies, reports as high as 60%. And oftentimes, actually, the patient does not want to be triaged outside of their community to a level 1 trauma center, which is another factor that plays a role. They want to remain in their community. So sometimes the fact that they're not getting to the right level of care may play a role, but it may also be the personal decision-making that plays a factor here. But considering is the patient making it to the right level of care is appropriate. Once they get to us, one of the questions is, are we obtaining an accurate history? We've been looking at this because patients come in, they oftentimes can't give us a history because of the injuries that they have. They might not be family available, might not be records available with them if they're coming from outside hospitals, might not have EHR systems that don't talk to one another. But a lot of times we've seen that there's not been data recorded, and patients might have been on a beta blocker outside the institution, and now we don't have them on that, and we know that that makes a difference in outcomes. So understanding the history and usual medications is really important, and getting that information is really critical as soon as possible. So that's one of the pieces that we can be doing, is focusing on getting that history as soon as possible, within the context of the care that needs to be given. And so paying attention to that, because that's definitely not just beta blockers, but some of the other medications, if you abruptly stop, clearly make a difference. And so that's an important factor. We've also, this is from RAND study that looked at what care has been given to older adults and what examinations, that these are recommendations should we be doing. We should be doing orthostatics, be assessing vision, gait, and balance, and doing a neurologic exam after a fall. And this gives an example of what we are and are not doing in the case of this RAND study, that we are missing pieces of what exams should be given to an older adult after a fall to further reduce the risk of, to understand what risk factors they may have, and to put them, identify appropriate treatments to reduce the risk of fall in the future. So we're not necessarily doing the most comprehensive exams when they come into us after a fall, and so making sure that we're doing these pieces, or if they're in the emergency department, we're sending them back to make sure that that's being done as part of transitions of care if we're not assessing vision. For clinical management, making sure as an initial assessment that we're looking at what the comorbid conditions, understanding, did they have a prior head injury, making sure we're doing a good neurologic assessment, following that initial exam. And then both the Canadian criteria and the New Orleans criteria recommend head CT in older adults who present to the emergency department. And so those would be criteria to assess head CT and who should you be getting a head CT on. So the vast majority of older adults who are going to be presenting to emergency departments will probably should be getting head CTs to rule out any intracranial pathology, because oftentimes the symptomatology, they may have a very benign neurologic exam, but might actually have intracranial pathology just because of normal aging changes, and that gets hidden. So red flags, being alert to these, making sure that, especially if patients are getting discharged home or discharged with family out of the emergency department or out of primary care, making sure that they are taught to be alert for these red flags, and that we're watching for them after the initial head injury. And they run the gamut from increasing confusion to slurred speech and thinking about just general changes in the neurologic exam. So the other piece to think about with following patients with mild traumatic brain injury, which again is the vast majority, more than 80% of head injuries, is to set expectation. And expectation is not that patients are going to magically become better. It's that this is going to take days to weeks, and sometimes, and in older adults, I would say it's more likely going to take weeks period of time, because it's a slower trajectory of recovery. So again, not setting, what we hear a lot from older adults and patients in general is, I didn't know what to expect. I didn't know what would be normal. And knowing that each patient is individual, but setting expectations that this is going to be a gradual recovery. You're going to have different symptoms. This is really important to understand when they should call, when they should not call. There are no specific drugs that are going to actually treat traumatic brain injury that are FDA approved. It's very symptom focused. Patients should avoid opioids and sedating meds, avoid alcohol, avoid anticoagulants, aspirin, ibuprofen, and when it should start or should it start at all, is a very open for ripe discussion, very controversial. Across providers have very differing opinions on this, and the literature is not clear. And then looking at, again, symptom triggered and focused assessment. And one of the issues that we see with older adults is that they often can't distinguish, well, is it because I'm older that I'm experiencing this symptom, or is it because of the injury itself? And so there are differences in the symptom experience between older and younger adults that we've seen. And so while younger adults are often complaining of headache as a primary issue and may complain of some other symptoms, older adults are more likely to complain about balance and fatigue. And so those are often the symptoms that we're managing after head injury in the older adult. And so fatigue is often, they can't parse this apart to say, is this because I'm older that I'm just normally fatigued, or is this worse because of the injury? And so oftentimes that might require a probing, and it's often not clear to the provider, to be honest, with that. But balance is really one of the prevalent symptoms, and often, and clearly that's going to put person at increased risk for subsequent injury, and so paying attention to that's important. So in thinking about the common problems of balance, we want prevalence is higher in older adults. Posture stability is an indicator of recovery, certainly something that's followed across concussion in younger adults. We want to assess in these patients, what's the contribution of vision? So vision could be contributing to balance problems. So understanding what is happening with the person's vision. Are they having issues that are contributing to this? Are there any issues with hearing that are also, or vestibular problems that are contributing to this? Are there medications that you could be thinking about for managing some side effects? Could also refer the patient for vestibular balance therapy to PT, and could consider some short-term pharmacotherapy, although certainly these drugs have anticholinergic effects, so have to be balanced against the risk of the anticholinergics in older adults. Another common problem, fatigue. 2/3 of older TBI patients have severe fatigue, and this can last not just weeks, but can be ongoing. Need to be thinking again about the secondary causes, things that are going to be highly prevalent in older adults at baseline, thinking about sleep disorders. Do they have baseline insomnia? Are they having issues with other sorts of sleep disturbance, obstructive sleep apnea, those sorts of things? So understanding, could this also be contributing, or do they have comorbid pieces that you need to be thinking about? Are they anemic? So again, a full assessment of the potential causes of fatigue and treating those to assess it. Recommending periods of rest, and then looking for possible requests for physical therapy for assistance with this. Graded aerobic exercise with cognitive behavioral therapy can also be useful in managing fatigue in the population. Again, sleep is co-contributing. It can certainly exacerbate other symptoms like pain and cognitive deficits. It's underappreciated. Starting with should start with non-pharmacologic management, thinking about sleep hygiene, and cognitive behavioral therapy for insomnia has been successful in traumatic brain injury patients, and so this within the population has been certainly useful in older adults without head injury as well, and so would be a strategy to consider, and this is available in a variety of formats that would be accessible. Pharmacologic management, melatonin can be useful in some patients, but again, avoid benzodiazepines as here. Memory impairment can be commonly reported, and just again, screen for risk factors for ongoing memory problems. Memory interventions, occupational therapy can be a useful referral strategy, looking at restorative or compensatory strategies to assist patients with these memory issues. Might see vision disturbance, and prevalence varies highly. And the other piece that I think is underappreciated is individuals may end up with olfactory disturbance and actually lose the sense of smell. And this can impact food intake and result in significant weight loss. And so one of the things that we recommend after a head injury is to monitor weight for potential weight loss, and they may require dietary referral for managing that, because with the loss of the sense of smell, that's not going to come back. And coming up with strategies to increase food intake is important. So because we don't have a strategy or a therapy that's going to actually, once a head injury happens, treat it at this point, it's all symptom focused or prevention of secondary injury. Management really starts with prevention. And because falls are the primary issue for older adults, that's really where a lot of this features. And so fall prevention, which we'll talk about evidence-based strategies, thinking about driving safety in older adults. The most common accident when the older adult is driving is left turns. And this is related to a lot of loss of range of motion in the neck. So there can be some things to do around safety. There are certainly a lot of insurance companies have driver safety classes, as well as AARP has driver safety classes that patients could be referred to for that, and also thinking about different activities that could be done for range of motion if that's going to be an issue. Treating, helping individuals with scanning techniques or those sorts of things for reducing risk if they are driving. Also, if you're concerned about cognition and safety, and doing assessments there. Personal protective equipment if they're out skiing still happens, and we see some of these issues in our patient population. Again, brown bag reviews and regular vision checks. And first cataract, if patients have cataracts, having that first cataract repaired actually reduces the risk of injury. There's no benefit to the second, but I'm sure patients feel better with the second. The CDC has a great education campaign that you can use for family members. This is actually targeted at the children of the older adult and less so at the older adult themselves. And there are also resources for providers, for healthcare providers and community members, with wall posters and handouts and things that you can provide to individuals. And so I've provided the URL here. It's called the whole campaign is called Help Seniors Live Better Longer, Prevent Brain Injury. It covers recognizing symptoms, to what to do, when to call providers, how to reduce risk as well. So in mitigating the risk of falls in older adults, again, the #1 cause of TBI, what does the evidence recommend that providers do? There is the CDC Centers for Disease Control has the STEADY toolkit, which is the Stopping Elderly Accident, Deaths, and Injuries. And it recommends a 3-step approach. One is to screen for fall risk using 3 questions. Have you fallen in the past year? Do you feel unsteady when you're standing or walking? And do you worry about falling? And if they answer positive to those questions, then going on and review and going on further and assessing. Reviewing and managing medications. Again, medications come up again and again for risk of injury, risk of fall. Recommending, although this is still on the website about recommending vitamin D, the new National Preventive Services Task Force guidelines do not recommend vitamin D for every individual. They just recommend for high-risk individuals. So this is a recommendation that's changed, but the STEADY toolkit hasn't quite been updated to reflect this. So just to make you aware of that. But evidence-based strategies, the STEADY toolkit has pieces in it that include the check for safety, which is the panel in the middle, the home fall prevention checklist for older adults. It's a great resource. You can refer individuals to that. You could actually use it with them. It goes room by room in the house and has what to do. You know, here's the bathroom. Here are the safety issues that could happen in the bathroom. Here's the bedroom. Here are safety issues. And so it gives an individual a way to go room to room within their own home or environment to assess what the risk factors are. Again, medication, coming back to medication review and doing that on a regular basis. Doing deprescribing when necessary, reducing the number of unnecessary medications, looking at medication interactions, just really that thorough brown bag review between the provider, pharmacist, really important to do. Vision check on a regular basis, and then making sure that individuals know that when glass prescription gets changed, that oftentimes it takes the brain a little bit to catch up with this, and that's actually a period of high risk. So I think if anybody's had their glasses changed, they know that oftentimes the depth perception is off for a little bit until your brain catches up with the new prescription. So making sure that they're aware that that's a particularly high period of injury, as well as older adults often have progressive lenses. And so going downstairs with progressive lenses or bifocals can also be particularly dangerous. So talking to them about if they should be taking them off at the top of the stairs, something to mitigate that risk if that's particularly a vulnerable time for them. And making sure that there are handrails, which goes with the check for safety. As far as the shoes, the feet, no bare feet. This is pretty, when I go and talk and do fall prevention talks to older adults in the community. Some of the work that was actually done here by Tom Kepsel at the Injury Center looked at footwear in association with falls in older adults and found slippers that were just regular house slippers and bare feet were associated with increased risk of falls in the home. And older adults are very surprised to hear that you should actually be wearing something with tread even in the home. Because it reduces the risk of fall. So thinking about footwear both inside and outside the home is important. And then exercise. Exercise is a great prescription for a lot of things, and I know the next speaker is going to be talking about that. So.
All right, thank you very much, Dr. Thompson. So it was a great look at the relationship between TBI and falls and some of the clinical and research perspectives and fall prevention strategies that are out there. We're going to now transition to Paige Denision.
Thanks so much, Kelsey, and thanks to everyone for the opportunity to speak with you today. My name is Paige Denision, and I oversee the Health and Wellness Department at the nonprofit social service organization Sound Generations in Seattle, Washington, which includes the Project Enhance Fall Prevention and Health Coaching programs. Additionally, I'm a member and current chair of the EBLC, a national collaborative of evidence-based program developers, administrators, researchers, and delivery organizations focused on measurably improving health outcomes for diverse adult populations. Next slide, please. I'd like to share a little bit more about Sound Generation. So if we can move to the next slide. Great. Just to kind of ground our discussion today, I think every community probably on the phone has an organization similar to Sound Generations. Our mission is supporting people on their aging journey through community connections and accessible services. Sound Generations has a wide variety of services addressing fall prevention and management, whether it's getting stronger in an exercise workout, training matter of balance leaders to address fear of falling, addressing medication and pain management with one-on-one and workshop education, providing nutrition through Meals on Wheels, congregate dining, or providing safe and accessible transportation. Through the Health and Wellness Department at Sound Generations, we offer a wide range of nationally recognized evidence-based programs locally to help older adults address fear of falling and manage chronic pain, chronic disease, diabetes, and depression. If we could go to the next slide here, we'll see what makes a program evidence-based. So we can look at these bullets and see that they're programs that have been rigorously tested in trials using a specified design. They've been peer-reviewed as far as the publication goes, full translation in one or more community sites, and there's dissemination products that have been developed and are available for public use to ease replication of the outcomes. A lot of advantages to using an evidence-based program. Here's 3 big ones that are bulleted. Measurable health outcomes, facilitating responsible stewardship of funding, basically concentrating those limited resources on programs that work. And you can focus on delivery rather than program development, so there's no need to start from scratch. At Sound Generations, we're somewhat unique as we license and support 2 of these programs nationally. While all of our services are available throughout the King County area, Project Enhanced programs and our data management services are nationally available and include Enhanced Wellness, which is a health action planning program to help those with chronic health conditions and aging with and into disability work through barriers and meet their health goals. And Enhanced Fitness, which is an ongoing group exercise and falls prevention class designed especially for older adults and proven to improve physical and social function, decrease depression, save healthcare dollars, and decrease unplanned hospitalizations. We're going to focus in on Enhanced Fitness today as an example of an evidence-based fall prevention program that addresses a great many of both the biological and behavioral risk factors for injury in older adults discussed by Dr. Thompson, specific to TBI patients, such as frailty, depression, and chronic disease. These risk factors can be reduced and managed through safe and appropriate, consistent physical exercise. So we're about 1 slide ahead of me right now. So if we could go back 1 slide, that would be great. Thank you. And to understand the development of an evidence-based program, let's start at the beginning of this one. Our starting point goes back to 1993. According to the U.S. Surgeon General's report that year, more than 2/3 of the older adult population was noted as physically inactive. And recommendations for this inactivity included regular physical exercise to help manage chronic disease, and it was specified 30 minutes should occur most days of the week and include strength and flexibility. So this led to a 1994 trial at the University of Washington, and I think I've caught up now. We can go ahead to the next slide. So just a brief history here. In 1994, the researchers at UW Health Promotion Research Center and Group Health Cooperative, an HMO now known as Kaiser Permanente of Washington, collaborated with Senior Services, that's us, we're now known as Sound Generations, to conduct a randomized controlled trial of a multi-component disability prevention program. 100 older adults were recruited for a 6-month study at a Washington State Senior Center in Bothell, Washington. And even before the pilot study ended, participants requested to keep the exercise class component of the intervention as a permanent activity at the center. In fact, it's still going on today. Not only were the center members excited about participating, but study measures showed that the intervention group significantly improved in fitness and health. 13% improvement in social function, 52% improvement in depression, and 35% improvement in physical functioning. The control group was comprised of center members who did not participate in the program, but who attended other senior center activities, and they deteriorated in these same measures over the same period. After completion of the original study, wishing to see the success of the program moved beyond the study site, partner agencies agreed that Sound Generations was best positioned to hold the license for the program and oversee dissemination. So our strategy has been to license, train, and support community-based delivery sites that adopt enhanced fitness. This strategy has been quite successful over the years and has balanced the need to maintain fidelity to the program protocols with the mission to expand the program's reach in a sustainable way. We can go ahead to the next slide. So in 2008, the statement that we originally saw in the Surgeon General's report to accumulate 30 minutes or more of moderate intensity physical activity on most, preferably all days of the week, was given more definition to say at least 2.5 hours of moderate intensity exercise, and 3 days of the week should include at least 30 minutes of the physical activity. So you can see on this slide in the orange or gold there, that enhanced fitness is offered 3 hours a week and 3 days a week for 60 minutes, meeting those recommendations, as well as being offered in a wide variety of sites to reduce barriers to physical activity. So, you know, faith communities, senior centers, parks and recreation, all kinds of different settings where it's available, and YMCAs are a large part of our work these days. Next slide, please. So this is brand new, out November 12th, but the U.S. Department of Health and Human Services released their 2018 physical activity guidelines for Americans, and this is just the second edition of these guidelines. And moving more was the primary recommendation across generations, but the 4 bullets on these slides are the new key recommendations for older adults. So as part of their weekly physical activity, older adults should do multi-component physical activity that includes balance training. We were really glad to see that called out, as well as aerobic and muscle strengthening activities. And there in the gold, you can see how enhanced fitness addresses that component and meets it. Older adults should determine their level of effort for physical activity relative to their level of fitness. We'll see more of this in just a little bit, but enhanced fitness has baseline and ongoing fitness assessments for upper and lower body, as well as agility, and that's an integral part of measuring the effectiveness of the program. It's also been proven to be safe for physically unfit older adults, and their seated and standing options. The third recommendation of the new guidelines are that older adults with chronic conditions should understand whether and how their conditions affect their ability to do regular physical activity. And unlike many group exercise programs, you know, we do health history intake as part of enrollment, and modifications that are created in the PT rehab world are an integral part of the enhanced fitness program. And the last key recommendation is that when older adults cannot do 150 minutes of moderate intensity aerobic activity a week because of chronic conditions, they should be as physically active as their abilities and conditions allow. And truly, this is the atmosphere in an enhanced fitness class. Go at your own pace is kind of our mantra, and it's really integral to instructor training and delivery. So how exercise looks in an enhanced fitness class, I'll tell you it looks a lot more fun than this diagram, but we use a train-the-trainer model to certify exercise professionals in the protocols, and these instructors lead participants through a 1-hour workout 3 times a week. And so starting with the orange slice of the pie there with the warm-up for 5 to 8 minutes to get the body ready for exercise, cardiovascular endurance work in the aerobic section there for 20 minutes, can be walking or a more structured aerobic routine. There's a cardio cool down to bring the heart rate down for 3 to 5 minutes. And typically in that cool down is when dynamic and static balance work is done, although it can be done at other points in the hour-long session. And that gets us ready for strength training using weights on the upper and lower body as appropriate. And we know what's appropriate because of the fitness assessments and health history intake. And there's stretching to wrap up the hour. So it's all-in-one class every other day. I'm going to go ahead and go to the next slide. So when someone does everything on that last pie chart regularly, what are the results? And looking at the bullets here, we can see that it's been proven to maintain or improve in all those areas, cardiovascular endurance, muscle strength, balance, flexibility, to protect against medical falls and fall injury, decrease depression, maintain or improve physical function, lower healthcare costs, improve socialization, and promote a physically active lifestyle outside of the exercise session. It's been designated a fall prevention program and also an arthritis appropriate program. So we're going to dig a little more into that in just a moment, but what's enhanced fitness look like today? Because of the ease and implementation and replicability in diverse community settings, many researchers choose an evidence-based program as their physical activity intervention in studies. So our Project Enhance programs have benefited from a strong continuing relationship with our original academic and healthcare research partners, UW HPRC, Group Health Foundation, and Kaiser Permanente of Washington. These relationships have provided many opportunities to participate in research, evaluation efforts, and pilots beyond the initial study. Currently, we have 2 randomized controlled trials underway or in the works. HPRC is in year 5 of a CDC-funded community clinical integration study with physical therapists, and in 2019, we'll be kicking off year 1 of an NIA-funded pain management study. There's a few other significant milestones on here I want to cover. We'll be talking in a little bit about data collection, data management, and how to use the data. And we created our own online data entry system in 2013. We have a national partnership with YFUSA that also began in 2013. We partnered with American Council on Exercise in 2015 to provide a deeply discounted ongoing continuing education to our instructors based on the chronic conditions that are noted most frequently on those health history intake forms. And then we're rolling out a partnership with FitTour, which is an online provider for those rural communities that are not that just can't find the right individuals to teach a class, since it's not lay leader led. This is a really inexpensive online basics in fitness certification that's available in Spanish, and that's something we've really been looking for. So we're really excited about that. As far as reach goes, currently we have 1,359 classes offered in about 800 sites in 44 states in the District of Columbia, and we're tracking over 88,000 unduplicated participants to date. We'll talk a little bit more about this 2013 CMS evaluation, but we topped the list of proven programs in savings of $945 per individual and healthcare costs per participant. In 2015, there was a retrospective study that compared enhanced fitness and a for-profit, well-known and very large Silver Sneakers, and it showed that enhanced fitness significantly protected against injury from medical falls. Next slide, please. So gathering data, we've been at it a long time. As mentioned early on, community evidence-based programs are measurable, which make them a good choice for showing ROI and responsible stewardship of funds. In the case of enhanced fitness, this slide shows the what and why of data collection in a very broad bullet point sense. So we're doing that health history intake and looking at self-reported health and fitness assessments. The data-driven world makes it easy to prove we're engaging your participants in improving health outcomes, and we're going to look at some of those reports in just a few minutes. But we do know that it works. So if we go ahead to that next slide, I just want you to, we're going to hear from a participant in just a moment. So this is the participant view. You know, it maintains or improves physical function. That's why they like it. It protects against falls, provides protection against falls injury as well if there is a fall, provides that social benefit. We often say we work our social muscles as hard as anything else, and promotes this physically active lifestyle outside of the session. So keeping all that in mind, let's look at a testimonial from a participant that illustrates what we're often seeing. This, I understand that this breaks all the rules about wordiness on slide decks. But I'm sharing it because it speaks to what we're seeing so much of presently and the importance of community fall prevention programs' role in sustainment to be not just back following injury, but better than baseline when possible. So looking through here, I'm just going to read through it really quickly, but I want to point out some things. So this participant had a fall, had knee surgery for torn meniscus, followed the doctor's and physical therapist's exercise plan for recovery for approximately 14 months and experienced some improvement. However, I was still experiencing pain and limited movement in that knee when I began the enhanced fitness program. I rarely miss a session, and I'm amazed at the positive results I've had in 8 months into the program. When I started, I couldn't do the chair stands without severe pain in that knee. At the instructor's suggestion, I modified the movement. I can now perform the move without arm support and best of all, without pain. I suspect the additional quad and hamstring exercises have also helped me. Now that gardening season's here, I'm noticing more enhanced fitness benefits compared to last summer. Greater strength and stamina when working in the yard and garden. Thank you for this awesome program and our amazing instructors who are so inspiring and supportive. Enhanced fitness participant in Washington State. And so, of course, this is all heartwarming. We're really glad to see these kinds of outcomes with participants. But as a program administrator, when I look at this, also noting the key points of the handoff after the physical therapist's exercise plan ended. You know, certainly there was probably a list of exercises given, but they also did a warm handoff into the program. And then the participant continues, speaks about 8 months into the program. So really engaging, being consistent, starts talking about the modification of moves and then being able to do them without pain. So regaining strength, improving strength. And then we find the participant in the garden working outside, you know, taking charge of their own health, working in the yard and garden. So we're seeing that mastery outside of the session. So really great to see. Next slide. So from the healthcare perspective, we know it works in reducing medical care utilization costs. Enhanced Fitness was one of 9 other programs retrospectively analyzed as part of the Affordable Care Act requirement, which directed the Secretary of Health and Human Services to develop a plan for promoting healthy lifestyles and chronic disease self-management for Medicare beneficiaries. The findings of the retrospective report related to Enhanced Fitness included participants in the program was associated with a total medical cost savings of $945 per individual. Participation in the program helped decrease unplanned hospitalizations. 1 unplanned hospitalization was prevented during the outcome period for every 20 to 25 participants, and participants saw a decreased mortality rate of 1.4% versus 2.9% among controls. Next slide. I was also asked to speak about where we want to learn more. And this is a great example from a United Way pilot that was done. Once we find some funding, we'd really like to dig in further to understand how a fall prevention, physical activity, evidence-based program can function as a supportive strategy in housing. We have many residential and public housing programs, but we're not measuring this systematically, and it matters, so we'd like to. So you can see in this project where there were some interventions in place and some health promotions in place, but in the buildings that also included Enhanced Fitness, we were reaching 73% of residents versus the 33%. So in this project, we think we learned that the popularity of the classes drew residents into the common area 3 hours a week, and it was a great way of connecting residents to other programming and hopefully to each other as well. So that's one area we'd like to dig into more. And then another area would be that we're part of the M4A's Health IT Learning Collaborative. So this is a recent startup for us. It just started in November. We're focusing in on using the evidence-based programs as an entry point to integrate community-based resources within the healthcare delivery system. So creating a bi-directional feedback loop pilot addressing the resumption of activity recommendation that Dr. Thompson mentioned, with a warm handoff post-care focusing on sustainment and improvement. And also when we think bidirectionally, We do regular fitness assessments. So if there's early identification of balance issues, early referral back to healthcare is something we'd like to look at too. So we're excited about that work. Next slide, please. We are a community-based organization, and we deliver other evidence-based programs as well as enhanced fitness, and have worked with academic partners for some time. So we understand the pain of paperwork, and this is what our offices look like prior to setting up an online data entry system. We had people sending in their attendance and their fitness assessments from all over the country. So we created this system internally, and the goals were to empower participants to improve their own health and keep them motivated by showing them their progress. Also to meet stakeholder reporting requirements and leadership ROI and make that easier for our affiliates, and to increase site engagement and bring them closer to their data to improve the understanding of why the protocols are what they are and fidelity to the protocols, because we know a lot of things work, we just know why this works. Our actual requirements for this system were pretty easy. We needed it to be remote real-time access because we work all over the country. It needed to be easy to use because a lot of the data entry is done by HIPAA-trained volunteers, and the reporting needed to be robust to achieve the goals on the last slide. So we'll focus in on the key data elements that we collect in order to evaluate program success and participant outcomes. These key elements are participant demographics, so we know who we're reaching and consequently who are not. Attendance data, so we know whether participants are receiving the dose of the program that's proven to result in positive outcomes. And fitness check data, so we know whether participants improve in objective scores and self-rating of health and fitness. Next slide, please. So looking at Washington State, since that's where I'm sitting, and looking at a sample of participants, I don't know if you can read this, the small print on your slide, but basically green is good. So we're doing these Weekly and Jones gender-based norms is the comparative for folks ages 60 to 94. And the green area is improved or maintained at average or above in these areas. So this table summarizes the change from one category to another from baseline to follow-up. And if we can go to the next slide. Pulling these data elements together, and this is test data, just to make sure everybody knows we're HIPAA compliant. Looking at the demographics, the attendance, the fitness checks, we can run a 2-page summary report for each participant showing an overview of the participant's activities and outcomes in the program. So this report's meant for the instructor to share with the participant so they can see their progress and the instructor can provide coaching and encouragement. We also have some additional optional tests that can be included when they're performed. A site chooses to perform and include them, which are the 1-leg stand for balance, the 6-minute walk, and the 2-minute step for aerobic endurance. So when we look at this first page, if we could go back for just a moment, when we look at this first page, we can see at the very top the consistency of the class, including first attendance, last attendance in this example. The attendance history is the graph there. The blue are the classes offered, with the gold superimposed are classes the participant attended. And then we have the self-rating of general health and change in physical ability. General health is the blue, and physical ability is the gold. And then on the back, or the second page here, that gold box, that's the gender-based norms from Weekly and Jones. And where you see the box change shape, that indicates that they are moving to a new age range. So this blue line shows the data points of fitness checks over the between first and last attendance that's pulled for this participant in the test data, and shows that they have that they were not meeting the norms. They were below norms for chair stands, and they over time are now within that gold box, so within the norms. And we see also for the arm curl something similar there. And then for the timed up and go, a shorter time improvement, right? Because they're able to move more quickly, and we see that they're within the norms there. So let's go ahead to the next slide. I could talk about that slide all day. So, you know, it improves health, but what if no one shows up? So based on over 10,000 participant evaluations, we do yearly evaluations. We can see that participants are very committed to this fun and social intervention, with 97% recommending the class. On to the next slide. You can see here how to find out more about enhanced fitness, but these are great resources for, in general, for evidence-based programs. There's a lot of great evidence-based fall prevention programs out there, like A Matter of Balance, Stepping On, Fit and Strong, for example. So ATEGO. So the National Council of Older Adults Healthy Aging Resource Center, Falls Resource Center, is a wonderful resource full of all kinds of information. EBLCprograms.org is the evidence-based leadership collaborative site, and has case studies and other location information on there for sites that have these programs. The Administration for Community Living has a Title III funded program list on it, and the CDC.gov has the Arthritis Intervention funded list of programs on it. And of course, the Aging and Disability Business Institute is a great newer resource that really gets into the business acumen piece of this work, and is just chock full of resources. This slide shows our public health and aging partners, and I'd be remiss if I didn't thank them and credit them for their support for this work, because their support makes it possible. And they help implement and maintain this ongoing exercise fall prevention program. Next slide, please. And I thought I'd just end this part of the presentation on this quote that came out of a study of medical claims done in Washington State over time. Definitely these health promotion programs and addressing prevention is very important. So I'll end there. There we go. And can go to Q&A. Thank you.
All right. Okay. Our apologies again for the feedback issue earlier. We fixed it so we can hear everybody and you can hear us. Perfect. We are going to go ahead and go into our Q&A time with both of our presenters. And if you look down at your toolbar in Zoom, you should be able to see a little Q&A box, and it'd help us out if you would type your question into that box, and then we can see them all in one place. And we do already have a couple questions that we can go ahead and get started on. I do have one about Project Enhance. So my question is, what does the fitness assessment entail? Is it an assessment you created?
No, it's not an assessment we created. The Reichley and Jones norms, gender-based norms for older adults, were created by Drs. Reichley and Jones at University of California at Fullerton, and they're widely used norms, and so we use that to evaluate against these assessments for how our participants are doing. We do the 30-second bicep curl for upper body strength. We do the 30-second chair stand for lower body strength, and then the timed up and go test for agility.
Great. We also have a question I believe came in during Dr. Thompson's presentation. In talking about role of providers, you talked about red flags that providers could look for specific to older adults. Is there a checklist that could be distributed to providers to use during history and monitoring? And if not, would this be something that would be beneficial to develop and disseminate?
As far as I know, there's not specifically a checklist that's been developed. I think that that would be something that could be useful. I would agree with that. Yeah.
Great. So another question that came up regarding kind of fear of falling, and this could be a question for both panelists, I think, what could potentially be done to help an individual who has a fear of falling, which, as you mentioned, leads to increased risk of falling also?
I can start. So one of the things that can happen with fear of that can be done for fear of falling is to recognize how it's impacting the individual, and then understand, and again, use sort of cognitive strategies around this. So that actually, and education. So helping the individual understand that by restricting their activity, restricting what they're doing, they're actually increasing their risk of fall, and then trying to understand what the fears are and addressing them. Making, like I was mentioning, appropriate referrals, so that if they're concerned that they're going to injure themselves, how can we refer them to physical therapy so they might learn safer methods of falling, and so that if they do fall, that they might not injure themselves when they fall. And also referring for exercise programs, actually, like Enhanced Fitness or other ones where they could be building up strength in a safe environment, that are adapted exercise programs for their level of, that are chair-based programs or other sorts of things that are for their where they currently are. But really, a lot of it has to do with cognitive and cognitive behavioral strategies to help them overcome their fear and understand the relationship to actually increasing risk of fall.
And this is Paige, and I just add to what Dr. Thompson said, and said that and recommend a program like the Matter Balance program or Stepping On, which are free, generally free workshop-based programs in the community that are education programs that work with a peer group cohort to really, they're like 8 weeks of kind of meeting together and really getting to the heart of that question. And so, they include everything from, the home safety checklist and discussing that among peers with a trained leader, to also having guest speakers come in, like physical therapists that go from everything, go through everything from how to walk with a cane to how to get up and down safely. So they bring in healthcare providers, often PTs in to do that discussion. And then they also start folks off gently introducing some exercises that they may want to do, and they tend to do a warm handoff into a class in the community of D, whether it's something like Tai Chi or, Enhanced Fitness or, Silver Sneakers or another class in the community. So this is a great way for folks to get together and form a community and break down that fear of falling piece.
Great. We also have a question about evaluating programs. What do you recommend to effectively evaluate a program versus one particular class?
Okay, so this is Paige, and I guess I need to know a little bit more. Like, are they working with researchers? That's one thing we hear at Evidence-Based Leadership Council sometimes, when folks have a program that feel they've pulled together and now they're not sure how to connect with researchers to do an evaluation. So I'm not sure if that's what's being asked here, or how to collect the data in aggregate to look at it. Certainly the Reekley and Jones norms are a great one way to look at it, but I guess I would need a little more information on that one. So.
Sure, but do you recommend maybe kind of connecting with researchers or forming a relationship? There might be a good first step if they weren't sure what direction.
Well, I think so, definitely. And I think if you're not sure how to do that, going to the Evidence-Based Leadership Council, so the EBLC programs.org website, and reaching out to the contact point there on how to do that and asking that question, because there is some TA available, some technical assistance available.
So for Dr. Thompson, what advice do you have to talking to, say, an individual about fall prevention or about good fall prevention behaviors?
So in talking to an individual, I think that first you have to understand what they perceive as their risks and what they value. Certainly if someone values independence and what you have to understand what their goals are, because and understanding that piece is exceptionally important, because I can talk to the moon and back about fall prevention and risk reduction strategies, but if the person overvalues that behavior over the risk reduction, then it's not going to go anywhere. So I think understanding that piece is really important in what they value, and because people have the right to fall. People absolutely, older adults with cognitive, anybody who has decisional capacity has the right to fall. And so understanding that piece, and then also understanding the other is important. But I think then taking on the, you have short period of time in visits, and so trying to understand what's the low-hanging fruit to go after at first, and then build up from there. So what are the pieces that they're interested in working on as well going forward?
Great. And I think we had a question about Project Enhance, in thinking about how the kind of the licensing fee and the grant funding kind of work together or interact with each other.
Absolutely, and I attempted to type into that one, but I'm happy to answer that. So typically the grant funding pays the license fee. I mean, that's how that piece works. The license fee is truly, most of that is the training fee. So it's bundled. So very little of that is actually the license that keeps the light on. Most of it's the training fee, and they're bundled together. And not everything's covered by licensing, but yeah.
Great. So one question I have, I think for both panelists, is looking at, we learned about some specific exercises. What are particular exercises or activities that are good, can be helpful measures in terms of if someone's improving in lowering their risk of fall? Or what are some of the things that we can look at in terms of physical ability, in terms of determining a person's fall risk?
So, I mean, I think the same things actually cross both. So we looked in the clinic, looking at the timed up and go. We look at chair stand. We look at balance, ability to balance on one leg with for 60 seconds. So those are pretty low hanging fruit that we do, looking at the balance test, and also then timed up and go, and are easily done in the clinic. And obviously are also being used other places. It's a little bit more difficult for us to do in clinic areas. 6-minute walks, there's not usually enough space to be able to do that, but so those are some things that we're doing. We, in our research activities, we're also using those we're currently testing some cognitive training programs for fall risk prevention right now, and are using those exact same tools out in people's homes. And so again, it's something that translates well from the clinic to people's homes where there's not a lot of space.
Did you have anything to add about those particular exercises that you've seen in your program?
Yeah, I think there's a lot of things that help, but to assess, we, at one point we were doing 7 or 8 assessments originally, and then, there's the reality of translating a academic study into a community-based setting and what's realistic, and landed on these 3 of the upper body, lower body, and the timed up and go, and that's been that's worked really well. So, and then for exercises, just doing all the muscle groups has really helped balance the body out.
So kind of another question about Project Enhance. Why do you use the bicep curl instead of the third assessment in CDC study?
I'd have to pull up study. So why do we use the bicep curl? Because we're looking at not just falls, we're looking at, and lower body, we're looking at functional strength overall. So having upper body, oh, I got it. Okay, thank you. So we're, you know, it really is a physical activity program, not solely focused on falls. So really looking at physical function and assessing upper body strength was a key consideration in choosing that assessment.
Great. And then another question is, what barriers do you see in adoption, either, you know, of an exercise program or of implementing fall prevention, maybe in the home or in other behaviors? What are some of the barriers you see there?
Can you say that just one more time, please?
Oh, sorry. I just, what are some of the barriers that you see to adoption or buy-in? So for, in your case, an example, to doing a regular exercise program?
Yeah, you know, I think there's a lot of barriers to exercise. And we know that even when we look beyond the older adult population, fitness facilities are not really activating any more people than they ever did. So, you know, how do we get that word out and reach people? You know, we are, so Enhance is more focused on underserved communities specifically. So I think one of the big barriers is, you know, there can be a cost barrier, certainly transportation barriers. There's just people realizing that they can do this, you know. So there's a fear. There's a lot of people who don't like exercise because of some past experience. So, you know, really working and meeting people where they are has been an essential piece to getting past that.
I would agree. I think it's also around any behavior change to adopt and sustain. It's the same sorts of issues, whether it's exercise or smoking cessation, it's the same sort of issues. So understanding how you activate an individual, how you keep them self-motivated, because this is going to be something that you're going to have to do. And so engagement, self-activation, self-motivation, and really being planful with that in the activities. And certainly, I think for older adults, something that is not appreciated as much is that time is a barrier. Older adults often continuing to work, they continue to have other responsibilities and duties, or might still be working, and so time becomes a factor. And I often have people who tell me, well, I'm busier now that I've retired than I ever was when I was working. And so I think people underappreciate and just assume that older adults have infinite amounts of time, and that's not the case.
We do have a question, I think, related to the cognitive training you mentioned earlier, which is occupational therapy being utilized for the cognitive training?
It is not. We're actually using an online program for this particular training that we're using with the cognitive training, so it doesn't involve an actual person that's engaged. But occupational therapy concepts and were used before in the development of the program that we're actually testing.
Okay, great. And then kind of for both, for a question for both panelists, which you touched on a little bit in your page, I believe, is kind of what would you like to see kind of in the future for your projects? So what would you like to see for the future of research and that level for you?
So I would like to see, there's been a lot of attention in community dwelling older adults, which certainly that's where a lot of individuals reside, but I'd like to see more reach into underserved communities. So thinking, Paige mentioned the rural community, which I think we're not getting good penetration and reach to for a lot of the programs. So those, also those living in assisted living, we have growing numbers of older adults with dementia that are higher, certainly going to be higher fall risk, and a lot of these programs don't necessarily translate very well, and a lot of individuals with dementia will be living in the community. So I'd like to see us thinking about those underserved populations and thinking about how we can do fall prevention in those individuals.
Great. And Paige, what's kind of the top of your list of things that you'd like to see in the future for Project Enhance?
Yeah, well, you know, we spoke about the integration through the feedback loops. That's definitely a big one for us, as is the public housing communities and doing a better job of reaching there. You know, especially, you know, sitting in Seattle today, you know, when we see some folks that are being kind of squeezed out because of income inequality, that's a real concern for us. So in our community, so being able to maintain, you know, and take charge of your health and stay working or doing the other things you need to do is really important. I think other areas we really like to see, we'd like to see greater fall prevention dissemination in Native American communities, Alaskan Native, Indigenous communities we know have high rates of falls, and how can we meet those needs. I know NCOA is now doing listening sessions, and we are looking forward to having that feedback and understanding how we can better adapt programming to needs that are out there. Dr. Thompson mentioned dementia. There is an enhanced mobility sort of a derivative program that's being looked at UW, and so we're very interested there as well, and see that as a really big need as well.
Great. Well, thank you very much to our speakers. We have just a couple announcements to wrap up the webinar, so we hope you'll stick with us just for these last couple of slides. Oh, wrong way. There we go. So recordings of today's webinar will be available in a few weeks, so we will email everyone who is registered for the webinar that we have your email address. We'll email you access to that when it's available. We'll also be sending along course evaluation. We do value your feedback, and we'll be utilizing this as part of our series. As we mentioned, this is a webinar series, and we hope you'll join us for our future sessions. So coming up in our series, we have kind of events all throughout the spring. In January and February, we're going to have live Ask the Expert Q&A sessions. Our first one in January will be on TBI and domestic violence. Our second in February will be on TBI research methods. In March, we'll have a webinar set up like this one on Return to Learn, which is dealing with pediatric TBI and returning to school after a concussion. In April, we'll have another live Q&A session on a topic to be determined. We hope your evaluations and feedback will help us narrow down a topic for that one. And then in May, we will have a webinar on TBI and health disparities. So as part of this webinar series, we've also launched a discussion board called TBI Topics for Health Professionals. You should actually have an email kind of sitting in your inbox now that has more information on how to access it. But we think this will be a great opportunity to continue the conversation, to build relationships with people across the country who are interested in TBI. And it will host webinar recordings, discussion questions, resource sharing, and that's also where those Ask the Expert live Q&A sessions will be held, is on that discussion board. So we actually encourage you to go to the discussion board today. You are the first people we are inviting to participate and answer a discussion question related to today's webinar. So we'd love to hear from you, and in what ways is your organization or community encouraging fall prevention, and what next steps could be taken. So our address for the discussion board is tbi-topics.boards.net. And we hope you'll join us there for the conversation. Registration is free, and you should have a message in your email telling you how to access that board. Thank you again very much to our speakers and to all of our attendees, and appreciate your time, and we look forward to seeing you again at our next webinar.